who are our daily inspiration to accelerate and optimize anti-cancer drug development. Thank you very much.
Thank you, Dr. Calvo. Questions? Microphone one.
Yeah, so other companies that have studied AKT over here.
Okay.
Other companies that have studied AKT inhibitors have talked a lot about glucose and insulin changes. Did you see anything?
Yes, that is a good point. Also, we were expecting a higher frequency of hyperglycemia. At the recommended dose of 500 milligrams QD, we saw 2 patients out of 12 patients treated, but it was grade 1 or 2. So for us, it was also a type of unexpected result.
So I'm not sure I understand why you're not continuing to escalate beyond 500.
That is a key question. As you could see, the toxicity profile for this drug was excellent. I mean, I think this is the easiest drug to administer to the patients I have ever had in my hands. The thing is that since the tolerance profile is so good, it is possible that side effects would not be a good driver to try to find the MTD. In addition to that, and this is important, the PK profile of the drug at the highest doses was starting to appear with a tendency for a plateau, probably because of saturation of the absorption phase. So also it was not very clear to our minds that increasing the dose could achieve a proportional increase in the exposure to the drug. So although from a theoretical standpoint, it is true that the ideal scenario would be to be able to find a biologically active dose together with a MTD, and then sometimes you can even do a randomized phase 2 to try to pick up the winner. Here it was not possible. And also, and this is part of the study and the pre-planned endpoints, the molecular pharmacodynamic results were also passing well the pre-planned threshold. So altogether, it was decided to recommend the 500 milligrams QD.
Microphone 2.
Yes, I'm Howard Figger from Millennium. Quick question and then a real question. Your LFT rule about DLT 5 days, grade 3, was that something that, is there a context about this specific drug that led you to that kind of qualifier? Or is that just something that is just generally done as part of your belief and the transient grade 3s with any drug don't qualify as a DLT? And my next question, my real question, has to do with what's the basis of your of going after mesothelioma? At this meeting, there's been some, really negative results, discouraging results, at least with the TORC inhibitors, Rapalox, and mesothelioma. And I'm wondering if you still believe there's something different about this pathway or this drug that would provide a basis for going after mesothelioma.
Yes. Regarding your first question, the answer would be the second answer. I mean, it is more like a conventional way of addressing DLTs regarding elevation of transaminases. With regard to the second question, we saw a patient with mesothelioma that was having a prolonged stabilization of the disease, so we tried to enrich the expansion cohort with this type of tumor types. Having said that, it is true that last year in ASCO, there were some preliminary data indicating some activity, preliminary activity, clinical activity of an AKT inhibitor drug.
Thank you.
Microphone 4.
University of Pittsburgh. I had a question about your PD assay. So some patients go up, some patients go down. Do you have any idea of your assay variability, sort of within patient variability at a same time point?
Yeah.
And are you sure you really have target engagement?
Mm-hmm. Well, that is a good question. Actually, the assay was validated at the preclinical level, but to be more specific in the answer to your question, I have to say that I don't have the specific data, but I will be very happy to send it to you.
Thank you, Dr. Calvo.